Okay. Kia ora, kia orana, talofa lava, whakalofa lahi atu, ma loilele, maloni, nisa bulavinaka, Maori, warm Pacifica greetings to one and all. Before I start, I'd like to apologize. Unfortunately, due to IT challenges on my end, you can't see me, but hopefully you will shortly. My name is Siufafonga Matangi. I am the Pacific Engagement Advisor for the Immunisation Advisory Centre, and I will be one of the hosts for today's webinar. Now, before we proceed, however, I'd really like to acknowledge the tragedy in Tonga and share our deepest condolences with the families affected there and here in Aotearoa, New Zealand. Our thoughts and prayers are with those who have been affected. I hope you don't mind. I'd like to open us up with a little prayer. Heavenly Father, we thank you for this opportunity to come together as a united workforce with our esteemed leaders and experts in this field, as well as fellow colleagues across the whole of Aotearoa, to share knowledge, wisdom, and understanding regarding COVID and how we can make a difference together collectively. Heavenly Father, we ask and pray that you'll be with us during these precious moments. In the name of your Holy Son, Jesus Christ, we pray. Amen.
Amen. Thank you, Fonga. That's lovely. And I'm Jane Morfitt. I haven't changed my name. I'm Jane Morfitt. I'm the COVID Clinical Education Manager, and I'm also one of the hosts today. And it's my great pleasure to have with us Professor Nikki Turner, our Medical Director, Peter McIntyre, Medical Advisor, Dr. Emma Best, or another one of our medical advisors, all of whom are getting to be familiar faces on our Zoom sessions. And also I've asked Andrea Tahini to join us, and she will be helping us with some of the questions relating specifically to Māori. We've got Bronwyn Robinson, who's been very helpful in designing the toolkit that you regularly see sent out, the new one due out next week, so she'll know what's in there if we get any questions coming up. Catherine Tobin, who's been working hard with some of the practical rollout of the 5 to 11-year-old programme, complete with syringes and needles and such like, should they be needed to respond to your questions. And then, as I say, basically, Diala is the last but not least. I knew there was one left there. Diala, who's been helping me do some work around trying to prevent errors when we're using different vaccines within the vaccination centres. We've had a few problems, and she's got a bit of information that we've compiled over the last few days to share with you. So with no further ado, let's press on with the questions. I just need to say that the chat function has been disabled. The webinar is being recorded, so people can watch it later. And if you want to type your questions into the Q&A button, we did ask for questions in advance. So we'll start off with some of the questions that have come through, and then we'll look at the questions in the Q&A. We've got an hour put aside for this webinar this evening, and we will finish at 6. So if we haven't managed to respond to your questions, don't forget you can always contact us on 0800immune.org.nz, and we can respond to them that way. Right, so let's, without further ado, we'll press on, and I'll start with some of the questions that have already been sent in. I'll just find them on screen. One question that we're getting quite a lot of people wanting clarity on is booster doses and children under the age of 18 and our current guidance. Nikki, is that something you're happy to go through?
Yeah, sure. Kia ora all. So the key message is that the booster vaccine we've got, the Pfizer, is licensed from 18 years and up. So for people, we are not recommending it for under 18 at this point. Now, remembering that boosters are important for adults, but particularly important for older people, important for people with medical problems. So those are the highest need groups to get their boosters on time, and then younger adults. Now, is there a role for boosters for people under 18? It's not licensed in New Zealand. So if you wanted to consider offering a booster to someone under 18, it would be what we would call off-label. It hasn't got MedSafe approval. The company has not yet presented the data to MedSafe, so that we could potentially give a booster to somebody under 18 if we thought they were at particularly high risk of disease. And this would be like the severely immunocompromised. Other countries in the world Some countries are offering boosters from the age of 12 years and up. In particular, the FDA has licensed it in America. So bundle rule, in general, we don't offer boosters to people under 18. However, if you had a particularly high-risk young person, you could consider it as a healthcare professional off-label, which is outside current MedSafe licensure, and that would require full informed consent and a prescription. I hope that answers it. Has any other issues around boosters? Happy to cover it more.
There is one more question that's come up, Nikki, which is asking about the effectiveness of the booster and how long it takes to be fully effective.
So two different questions to that. How long it takes to be fully effective. I think the general rules with vaccinology is the effectiveness of a vaccine would take a good 7 to 10 days to kick in. So we generally say you're not likely to have effectiveness for potentially up to 2 weeks after you've had it, but you'll be getting some effectiveness from 1 week. And a lot of the clinical trials were looking at endpoints from 1 week. In terms of how long does the effectiveness last? Now, once again, it's not a single rule fits everyone. Older immune systems, we find that your immunity wanes earlier. Younger immune systems, you tend to have longer lasting immunity. So there's no magic number. And also, as we know, we're still accumulating data on the effectiveness with Omicron. So at this stage, older immune systems, people who potentially might be a bit immunocompromised, effectiveness does wane pretty quickly from the first few months, whereas younger people, you get longer. Now, I wonder, Peter, if you wanted to add any other comments to that one, you might have some more thoughts.
Oh, hi, Nikki. Yeah, I mean, it's possible, with this third dose that you might actually get things happening even before a week, because even with the first dose, when the vaccine, the Pfizer vaccine first came out, there were things happening from a week. So it's conceivable that it might be even earlier than that, but I think it's good, to take that as a ballpark for sure. And I guess the thing in terms of how long does it last is something we always need to keep in mind, against what. So, if we're talking about, any infection, including an asymptomatic infection, it's going to, the duration of impact against that is going to be shortest, particularly for Omicron. But then if you're stretching out to more severe outcomes, things that might land you in hospital, then it's likely to be quite a bit longer. But we don't really have specific data about that for Omicron in the long term. But in the short term, it's definitely, the booster dose is definitely a whole lot better against those severe outcomes than 2 doses only.
Thanks, Peter. And there's just a couple more questions coming in here, which is a little bit of asking us to read the into the future. But do we think that booster doses will be brought forward more than 4 months?
So again, the principles of booster doses is that generally you want a long gap from your primary course to your booster dose. Now, the ideal gap would actually be at least from 5 months. Now, it's been shortened to 4 months, really in recognition that you've got a trade-off between your immunologically ideal gap, which will hopefully give you the best response, versus protecting people as early as possible. So we'd be reluctant to shorten the interval even further. We are aware some countries have done that. And there could certainly be potentially a case for very high-risk people, like, once again, very frail elderly people, older people in general, and people with significant medical comorbidities. If they have got less than a 4-month gap, we are seeing Omicron increasing in the community, then that's a trade-off between having a non-ideal gap for your booster versus getting protection in as quickly as possible. So it's really about watch the space. We'd like to keep the longer booster gap where at all possible. But, if we really feel the importance of protecting people as Omicron cases increase in the community, then that's worth a discussion. But it's not a single rule for everybody. Remembering, once again, young, healthy immune systems are less likely to need a shortened gap and less likely to need a booster than older people and people with significant medical problems.
Lovely, thank you. And we may get some more questions, but I think that's covered most of the booster dose questions that we had sent in and the few that have come up on screen for now. So If we could move on to pregnancy, if that's all right. We've had quite a few questions coming in about pregnancy, and sort of really to summarise, I think people are interested to know how come the guidance has changed from when we first introduced COVID vaccine, and just to clarify what our current guidance is, particularly around booster doses in pregnancy.
Do you want me to have another go at that?
I think so, Nikki, sorry.
So look, originally with the clinical trials originally done, pregnant women were excluded from the original clinical trials. So when vaccines were first licensed, like well over a year ago, at the just over 12, 13 months ago, there was very little clinical data on the safety in pregnant women. Now, firstly, these vaccines in principles are not live vaccine. There's not expected to be any safety concerns in pregnancy. But of course, we all want safety data, and the original clinical trials didn't have them. So the original communication that went out was, we don't expect there to be any safety concerns in pregnant women, but caution because we're waiting for further safety data. Now, since that time, you know, the huge amount of people around the world given the vaccine has given us a really fantastic ability to collect safety data on pregnant women. And now the safety data in the real world from the countries who are looking closely at it, large American databases, British, European, we've now got accumulated data on a primary course in pregnancy that shows there are no safety concerns. So that backs up what we would expect. So we then could become very confident and say, your primary course in pregnancy, we've got good safety data on it now. It's likely to be both good safety profile and effective. Alongside that, pregnant women's risk from COVID is really, really high. And that was also what accumulated over last year, the awareness of the risk to pregnant women of COVID disease. So hence, really pushing our messages that it's really important for pregnant women to offer them protection at any stage in pregnancy. Now that booster doses have arrived, the question is, are booster doses safe in pregnancy? Well, once again, we know that a vaccine, a Pfizer vaccine, has got a good safety profile in pregnancy. So we would say the same, if you're due to have your booster dose and you're now pregnant, then we've got good accumulated safety data around being given a dose in pregnancy, and there shouldn't be any concerns. What we don't have as yet is a large amount of safety data, particularly for those small amount of women who might have had a primary course and then also a booster, all within your pregnancy. So once again, from first principles, we would not expect there to be any safety concerns at all. But as yet, the data is just starting to accumulate for that group of people. So primary course, good safety data in pregnancy. We're assuming the same principle would apply for a booster, and we will continue to watch the safety data closely. But importantly, pregnant women are at high risk of severe COVID disease, so the importance of offering them protection through vaccination.
Thank you. Is there any difference between effectiveness of the Pfizer vaccine against one or other of the two variants, Delta or Omicron? We've had a few questions around those sort of issues as well.
Yeah, so I'll sum it up briefly, and maybe Peter or Emma might want to add a bit more in. So there's a difference. What we do know with these vaccines is the effectiveness to severe disease is still very good. It's not quite as good as it was to Delta, but these vaccines are still showing that they are highly effective to severe disease. And that's the importance. The importance is vaccinating people now to prevent hospitalizations, intensive care admissions, and deaths. And we've got really good data internationally, even with Omicron, that these vaccines continue to be effective. We have lost, and the effectiveness to mild disease is less than it was to Delta. So the effectiveness at that level is less. And this is a virus that can spread more rapidly through the community. The vaccines will still have some role to play in reducing transmission, but not as effective as they were for the Delta. Now, I don't know if Peter or Emma, you want to add in any more. We've got some specific statistics and graphs if people would like them, but those are the general principles. Do either of you two want to add anything else?
Well, I'll hand over to Emma, as I chipped in before.
No, as Nikki said, there are some specific graphs that are showing that just having any symptomatic disease is improved by the booster dose against for this. But yeah, exactly. No, I don't have anything more really.
I'll tell you what, just out of interest,
Yeah.
just a couple of sound bites if it helps you. So if you're going to present to hospital with COVID, you've got about a third of the risk with Omicron as for Delta. So just so that you know that it's still effective, but you've lost a bit.
There's a question here that sort of leads on in a little way. It's what's the difference in the amount of antibodies you acquire naturally from getting COVID compared to that you would acquire through vaccination?
Well, that's a pet topic of mine, so I'll.
Yes, I was thinking.
I mean, it's. I think it's very important to understand that actually antibodies is not the only thing to look at, and the data about what happens if you have an infection either before you get a vaccine, or obviously preferably if it's going to happen, that happens after the vaccine, is that what happens is firstly you do get a kick up in antibody, and you know, we've only got a little bit of data on that from Omicron, but we've certainly got quite a bit from Delta. So an infection does act as a really good booster if you've been vaccinated, but it seems to also increase, you know, the breadth of the immune response. So not just antibodies to the spike protein, but antibodies to other components of the virus, and a broader spread of the cellular immunity. And so it looks like, you know, once you've had an infection after a vaccination, you're probably in better shape for the next variant that comes along, or at least that's been the case when you look at, you know, Omicron following Delta. I mean, these are all things which you never know for sure till because there are curveballs coming all the time. But certainly, there's a comment from one of the great fathers of vaccinology, who must be getting close to 90 now, Stan Plotkin, who said that polytheism is better than monotheism, i.e. the sorts of responses the immune system gets to the whole virus or the whole bug are typically, you know, stronger than the ones you get to just a bit of it. And so, you know, I guess that's where the story is. We wouldn't want to talk about infection being a substitute for vaccination, because it's not, but it does turn out that if you've already been vaccinated and then you get an infection, there probably are some good things, some upsides about that situation.
Another question that's come in that again sort of overlaps a little bit is, will the immune T cells be effective against Omicron after booster doses for severe disease and hospitalization after the antibody wanes?
Oh, sorry, I'll answer that. So interestingly, there are concerns that the antibody response with Omicron is definitely blunted, and it's not as good as we'd like. So we are going to rely on cellular immunity, and the early data to date does suggest that you still get cellular immunity. Time is going to tell really how effective it is or not. You know, the Omicron is still very early with us, and we're just going to have to watch and wait and see how much real protection we will get following boosters. There's just still data accumulating rapidly, and we're just going to have to wait and see.
Right, thank you. Let's give the medical team a break for a couple of minutes and look at some of the practical questions that have come in. This one, I think, Catherine, you might be able to answer, or I'll certainly join in if needs be. So if we draw up with a 25mm needle for the bigger arms, and there are 16mm needles to swap back to, and we don't end up using them, I'm just trying to work out what they're actually asking. I worked the weekend and had 1mm syringes which came with 16mm attached, so no spares. So basically, let's just talk about if you have the wrong size needle and you need to swap. So either you've got the short one or the longer one.
Yeah, so you'll know in your consumables, you'll get the 1mm low dead space syringe. So it's got that black plunger bit in it, and that comes attached with a 16mm needle. And obviously, if you need to use a longer needle, you can take that one off and just apply a regular 25mm 25 gauge needle. Note the low dead space 25mm 25 gauge needle will not fit on the LDS syringe correctly. You know, you'd really have to try and use a lot of force to get it on. It doesn't sit in there well, and obviously that black tip is going to start hitting off it, and it's not going to work properly. So remember, if you need to swap to a larger needle, just a regular 25 25 gauge needle. I guess if you're not using the one attached, once you break that seal with the syringe and the needle, it is open to microbials. I don't know, Jane, would you recommend leaving it in the packet? And if you needed to go back to it, you could, or will they be getting, I think what that person is asking is, will they be supplied with a box of 16 millimeter needles separately?
I don't think there will be 16 millimeter needles separately. I think they are coming specifically attached to those syringes because they're the ones we want them to be using for the pediatric vaccine doses. If you need to draw up longer ones, then you can either waste your 16 millimeter needle and use the 25 millimeter instead for 1 or 2 of the doses, or you can use one of the ordinary 1 ml syringes that you're using for adult draw up vaccines. But please, please, please make sure you are labeling your vaccine so it is really clear and you're not relying on what the syringes look like to decide whether it's an adult or a pediatric dose. And also make sure that you're always using primed needles, i.e. that the needle must contain vaccine and you're not just swapping the needles over, because if you take a 16 millimeter needle off and put a 25 millimeter needle on without having made sure that the needle's got vaccine in it, you will end up giving less of a dose than you should be giving. Right, I'm just trying to juggle doing several things at once. A couple of other practical questions that have come through. Can we just talk through the reasons why vaccination sites, particularly GP practices, can't just press on and give the COVID vaccine for children without having to register with the DHB? And I think Diala, perhaps you could talk through the process and also why it is we want, not just what we, but why the DHB want to know who's delivering the vaccines and making sure that they've got appropriate systems in place.
Well, I guess first and foremost, it's patient safety. And as Emma knows, paediatric patients are a special little group that we need to be very careful of. They're not small adults, they're a whole group unto themselves. And so we want to make sure that when a vaccine is given to our paediatric patients, that it's given correctly and safely. And I think the DHB wants to ensure that as well. So it's about making sure that the vaccination site has done the correct paperwork and is then processed by the DHB, and they are then have the correct staff who have done the paediatric course and that they're ready to go. So I think it's really about patient paediatric safety. Is there anything else you'd like to say about that, Emma, seeing you're the paediatrician?
No, I didn't even know the GP practices had to register with the DHB. And needing to know that they have their appropriate adrenaline and other things as they would. Yeah. And Peter's a paediatrician too, but that sounds like we document exactly who's getting the vaccine too, so we can make sure we're ensuring what the actual coverage is as well.
Okay, great.
Can I just remind people, if you've got questions, pop them in the Q&A button for us. We're working our way through them. Emma, there's a question here regarding what's the ideal spacing? We say in our training for the 5 to 11-year-olds, 8 weeks is recommended, but we do allow 21 days. So what advice should people be giving to parents, and why do we recommend 8 weeks?
So recommending 8 weeks because it is a good, the children good antibody response, and a second one will give them a nice, mature, longer lasting antibody response, but they'll get protection from any of the rare but serious complications of COVID if they should get it from one dose. And an 8-week gap is a nice length of time for the immune system to recognise and mature over that time. But then children who've got medical risks or immunocompromise, getting them 2 doses in more quickly will be more appropriate. And someone asked if you needed to have a script for that. It is actually licensed from 3 weeks. So I think if they had a reason and their doctor was happy with it, they could actually come and request the vaccine at 3 or 4 weeks, ideally if they wanted to, a gap. I think that's correct, isn't it, Jane? Because it is actually licensed from 3 weeks, but we want the gap to be 8 weeks. And that's for most healthy young people, that will be, or children, that will be a good gap for them. We did start with our vaccine gap even for the adolescents at 6 weeks as well. You'll remember middle of last year.
Yeah, and just to add to that comment of Emma's, I guess the other consideration, and there's a lot of questions coming through from parents about this, is what about safety issues? And one of the other things that was driving the 8-week idea, as well as getting better antibody responses, was, it seems like the whole myocarditis thing is a much less common thing in the 5 to 11-year-olds, which is great. Something like 1 in 250,000 after the second dose, and that's almost all boys. Not that that's any consolation really, but there is some quite convincing data from Canada now, where they had quite a lot of people who got big gaps versus small gaps, and it does look like you're less likely to get myocarditis if you have a longer gap. So in terms of having the absolutely lowest possible risk of that, bearing in mind that it usually is mild anyway, then having that longer gap seems like a good idea, unless, as Emma says, there's some reason to be concerned about risk to the individual, whereby you might be happy to go with that shorter gap.
And perhaps I can ask this question to Emma on the back of that. How do we answer questions to people about any risk, long-term effects of the vaccine when there is no long-term studies, especially to parents? So I assume they're referring to the pediatric vaccine.
Well, so I think we have lots of long-term information about this vaccine now. It's being used now in children, in young people and adults for a long time. We have a year or more of information. There's also no biological reason that we expect to see long-term effects. The vaccine is taken up in the body, stimulates our immune system, completely degrades and go away. So we know that these side effects and adverse events we see happen in that 1 to 2 day time after you have the vaccine. And then we know, we look at big population data, we can get the information that in that 1 to 2 weeks after the vaccine, we've seen the myocarditis that Peter was talking about happening. But they're not something that's happening 6 weeks, 12 weeks, 3-4 months later. And we don't see that with vaccines as side effects anyway. That's not normally it's not biologically how things happen. We see the side effects happening immediately as the immune system is stimulated. And then we can look at big population studies to see that in that first 2 weeks, the rates of myocarditis for maybe teenage boys was higher than we expected to see after the second dose. So we've got that information already, and we've already got information from several million children who've received the vaccine in the US after the first dose to say that. So I talk to parents about long-term side effects, more that it's long-term safety information from many doses being given is how we look at safety as well, rather than thinking about their child being unwell next year from a vaccine they received yesterday.
Yeah, and important to also say that if you are going to get long-term problems, it's from infection, not from vaccine. And we've already seen, with this relatively rare kind of hyperimmune response after COVID, that can happen weeks later after the infection without necessarily even knowing you've had an infection. So that's an example of something longer term, and it's something that we've seen with measles and chickenpox and a whole lot of other viral infections. But it's the infection, not the vaccine, we need to worry about in terms of longer term stuff.
And that's true of the small chance of long COVID, which happens, we know, for teenagers and adults as well. So the infection causing that is the concern.
Emma, can you talk about how long we would want parents to wait if a child had had COVID disease, or if they caught it overseas and then they're ready to have their children's vaccines? Or actually with anybody having a COVID vaccine post-disease?
So if you've had COVID, your actual chance of getting it again is much less in the months after that. So we're saying up to 3 months after you've had COVID, you don't need to have a vaccine because your risk of getting the infection again is low. It's the same for children that even if they've had asymptomatic or mild infection, are unlikely to get it again, except that children do have an asymptomatic infection. So you might not be aware and they can get the vaccine. There isn't a safety issue necessarily with it being given. At the moment, the handbook says any time from a month after you've had a positive test or had COVID, but we're looking to make that more like 3 months, I think, Nikki, is the discussion we're having at the moment. So because of that risk of getting reinfected quickly is less likely, you have some immunity, it's just not as long lasting. It's still important to have the vaccine after the infection to give it a different and broader immunity as well. But 3 months after infection is what we're starting to advocate for.
And for the older people, just to be aware now that the exemption process would allow for that to have a bit of a time gap. If you're PCR positive COVID, that you can get an exemption for up to 4 months to allow for the 3 months before you revaccinate, before you complete your vaccination.
Right, this one's coming. I'm not sure if we've completely answered, because to be honest, I'm concentrating on the questions, so apologies if we have already gone over it. But parents who are wanting their children under 18 to have booster vaccines, what advice?
Yeah, so we'll go over this one again. Once again, the data to allow licensure in New Zealand has not yet been presented to MedSafe. So New Zealand does not have licensure to approve vaccines in under 18s. Now, a few other countries do have, and we particularly, as we mentioned earlier, the American FDA has approved it from 12. So it's not licensed in New Zealand. And generally, the vast majority of 12 to 18-year-olds get a really good response to a primary course of 2 doses and don't at this stage need a booster. However, you would have a few 12 to 18, under 18-year-olds who may be at very high risk of COVID. And you'd particularly think about, you know, teenagers with severe immunocompromising conditions or on immunocompromising drugs. So you might have a case where you think this would be valid for this person to have a booster dose to boost their immune response. Now, in that case, it's outside of licensure, it's outside of current MedSafe approval. It would have to go through an off-label process where the medical practitioner was comfortable with the process, had discussed it with the individual and with their family, if that's appropriate, and they write a prescription for an off-label process. So this is a case-by-case basis at this stage, and it's an off-label situation.
If I could make a comment, a personal comment as the father of a 16-year-old son who has had 2 doses, I would definitely not want him to have a booster because, you know, he's, you know, fit and healthy. There would be an unknown but possibly higher chance of myocarditis after a booster in a male who's in that age group. And if he did get infection, he would almost certainly brush it off like nothing. So I think we need to be, you know, just a little bit reassuring, recognizing the parents' understandable concern of parents and doctors looking after kids with significant medical problems and the risk that that poses. But for healthy teenagers, I think we need to just say, look, you know, it's not something we need to be worried about just at the moment.
Just reading comments, but my headset's not working so well, so I'll do a bit of switching around. But meantime, Diala, do you want to just talk us through some of the common errors that we've seen and some of the key messages that we want to remind people about processes they should be following to prevent these errors, because it is concerning that we are seeing a few cases where the wrong doses of vaccine are being administered.
Okay, sure. Here we go. Well, we've been looking at the medication errors that have been collected by CALM. And the #1 medication error is expired vaccine being used in a vaccination process. So I think, please double check your syringe. Please double check the expiry, especially in the mornings when you're coming in and there's a trolley and there's been vaccine mistakenly left overnight. So that is the most common scenario of where expired vaccine has been used. The second most common medication error is an adult dose being given to a pediatric patient. And the third is a pediatric patient being given an adult dose. So please double check your syringe before you put it into someone's arm. So please double check. With the low dead space syringe, it's quite nice. It's got the little black piece within the syringe. So please look at it and please double check, because we certainly don't want to be giving adult doses to pediatric patients. It's just not safe for them. Then the fourth most common medication error is a booster being given too early. Please remember it's 4 months. So if today is the 27th of January, then it's the 27th of October. So just know those dates in your head before you start vaccinating. And then unfortunately, the fifth most common medication error is a used needle being used for vaccination, which of course can lead to many difficulties if the person who has been vaccinated with a used needle picks up some disease process that they didn't want to pick up. So please, I think the big thing is double check. So double check the age of a child. Ask the child their age before you put the needle in the arm. So please, the big thing for me is please double check everything. Thanks.
Thank you, Diala. I know it sounds like we're teaching you to suck eggs, but we're also very conscious that the stresses that people are under and the pressures with large queues of people trying to get through and get their kids vaccinated does make it harder to concentrate. So yeah, hence the really importance of us emphasising go back to basics and just take your time, even if there is a queue. So a couple of questions are coming here around communications and consent issues in particular. Could we have some clarification on exactly who is able to give informed consent for a child prior to having the Pfizer vaccine? This is something I will ask our paediatricians to talk to. I don't think it's a new issue. It's nothing special about the Pfizer vaccine than any other procedure or process that we put children through. But of course, we are keen to make sure it's an informed decision for those that have parental responsibility or who are the main caregiver for that child. Emma, do you want to have you got anything to add to that? Because I think the issue is people are concerned that it isn't always the person with parental responsibility in law that is actually looking after the child. And so for some of our communities, particularly within the Maori community, it can cause problems if we are insisting that we have to talk to the birth mother or the birth father.
So I guess I don't know exactly what would happen in a vaccine centre. I mean, obviously I work in a hospital and we have ways to find out the legal guardianship status of children. So usually you can establish that, and hopefully you can establish that at the time you're doing anything as a person in a clinic or a vaccination centre, as in who is a legal guardian, or get a parent on a phone if that's so there with an auntie or another family member. So that's something that has happened quite a few times. I'm sure parents have been able to nominate on phone. In fact, I had to take my friend's child in because she's unwell, and we were able to do it that way. So I think as long as you're able to get hold of the legal guardian who is parent or otherwise nominated carer, then that's should be straightforward.
That's certainly what we've covered in the training. What I would just add to that is that we are aware, and the ministry is aware, that particularly with informal adoptions, there can be a few challenges, and it is an area that they're looking at. And they have said they hope to publish more guidance on that in the near future, because we do take on board some people's concerns. But generally, it's a case, like Emma said, of let's just communicate by phone with the person, you know, but father or the mother or father of the child, so that we can confirm, or social or talk through to I was going to say social services, New Zealand version thereof, to ensure that you've got, you know, social worker sign off if the child is in care.
And could part of this, Jane, also be people asking if you've got anti-vax parents and particularly an older teenager who wants to get vaccinated? Is that
that's a good one, Peter. I was thinking of the very young ones who wouldn't be consenting for themselves, but you're absolutely right. If you've got an older child who is able to give informed consent, then they are able to consent for themselves. And there is some documentation on that the ministry has put together specifically to help respond to questions and support staff with those more tricky situations. But again, it's not new. We've these, you know, older children have always been able to give informed consent, provided they've got the capacity to understand the benefits of having the vaccine and the risks associated with the vaccine versus the risks of the illness, and also the risk of mum and dad finding out if they're anti-vax. I don't know if anybody else wants to add anything around consent issues. Okay, let's have a look and see. We've got a few more that we still haven't responded to. I'm sort of interspersing some of the ones that are coming in, that came in advance.
Jane, there is quite a few around the dosing of the pediatrics in regards to children's weight.
Oh, lovely. Thank you. Yep, we'll do that one then. Let's go for those. Emma?
Well, I mean, I think I talked about this in the webinar as well, but we it has been not arbitrary, but a decision, and that's the program is the 10 micrograms, and that's very appropriate for the immune maturation stage of children. The studies showed when they gave them 10 micrograms, 20 micrograms, or 30 micrograms that they had more fever with the bigger dose, but they have a very good immune response with 10. So there is no issue around it not being enough, so that's good. It's not really a weight-based thing. It's about your age and your immune system ability to have it mount a good response. We've had quite a few calls around doses given around that age of 12 or 13, whether they were pediatric or adult. They'll have a good response as a 12-and-a-half-year-old and 11-and-a-half-year-old, but the cutoff is 12. So we're very confident about the immune response for the 10 microgram for the 5 to 11s and the 30 microgram for the older. But if an error did happen, it's actually also going to be a good immune response both ways on either side of that age.
And to back Emma up, if you think about the weight differential in lots of adults, we can have very slim elderly people and very small people and very big people. This is about the immune response, not the body weight size. So, Emma's point about young immune systems, it's not directly about body size. So This is not a body size argument.
Yeah, but I suppose it is a flexibility thing too, isn't it? Yeah. I mean, and we've had it from both ends. We've had examples of where a 12-and-a-bit-year-old got very upset that they got a pediatric dose because they were waiting till they were just over 12 to have an adult dose. And we've had examples of, the 26-kilo 12-and-a-half-year-old whose parents very anxious about getting the adult dose. So we've had it from both ends, and I think we all feel pretty relaxed about the pediatric dose in that kind of, grey zone up to 14, and likewise feel less comfortable about the adult dose under 12, but it's happened hundreds of times, at least in the US, hasn't it? And there haven't been any specific bad stuff which has happened.
Thank you, Peter. That's helpful. Let's just check through.
Just briefly on consent here, Jane. One question is, do we need to have written consent, or can it be verbal?
Yeah. That's a good one. No, you don't need written consent. We do need written consent for something that's considered to be higher risk. So with the AstraZeneca vaccine, we want to make sure that we have documented evidence that the person having the AstraZeneca vaccine has had the discussion about the risks versus the benefits, but we don't need written consent for the children's vaccines. It's fine if you parents want to complete a consent form, or if that works well for your vaccination site, but it's not a requirement, it's an option. Same as for the adult Pfizer vaccine. How effective is dose 1, Emma? That's one I think you could answer quite quickly. And should parents delay taking their children back to school until they've had dose 2? And again, that would then mean that they were thinking about shortening the spacing to get dose 2 in.
I think we talked about what we mean by effective, about what's the end point we want. I think I would feel reasonably comfortable. I mean, we haven't got information about Omicron, and we haven't got much information about one dose in children, as in how effective it would be, but they have a good immune response. And if what we want to prevent is the small chance of hospitalisation should they get sick from COVID, then I think that one dose is going to be pretty effective for children preventing that. We know that one dose for 12 to 14-year-olds against Delta was 85% effective. So it's pretty good. But so I don't think we need to rush to give them the second dose before they go back to school. I think we have to accept that Omicron may occur, but it is actually a less severe illness, and it's a less severe illness in children, and one dose is going to be important to prevent those direct uncommon but hospitalization and those things. So I don't think people should be rushing or worrying about the second dose. It will come, and it's good that their children will have the 2 dose to give that longer lasting immunity. I mean, effectiveness against symptomatic infection or just any cough and cold is going to be less good with 1 dose. But that's potentially true even with 2 doses. It's not going to be perfect to stop transmission, unfortunately. We know that, seeing how much Omicron's happening in the world.
We've had a couple of questions coming here, just changing the subject slightly, about vaccine mandates and who advises people on vaccine mandates, and also commenting on the validity of informed consent when person is actually feeling pressurized that they've got to have the vaccine anyway. So is it actually informed consent? So maybe Nikki, you'd like to talk about our stance on those.
Yeah, so look, we're the clinical advisors here. We don't make the political decisions. So vaccine mandates is really a bit beyond our mandate. So we can give clinical advice. And I see I've answered 1 or 2 questions around the role of boosters and why healthcare professionals should have mandates. I'm not personally going to make any comments about the politics. I think there is some evidence that mandates do overall increase your coverage to some extent. How much they increase your coverage is hard to know. So one could make a community argument that mandates pitched well, effectively within a community, if they increase coverage, overall will add to protection of a community. So that's the argument for mandates. And one can argue in which role and for which people that's effective. And I think, you know, that's a discussion to have further. And then there gets a little bit of politics tied into that. I think separately from the mandates, there's a clear and compelling reason why healthcare professionals should have both their primary course plus their boosters. First and foremost, individual protection, particularly for severe disease, but also, even though we know that these vaccines are the COVID vaccine is less effective against the Omicron strain, there is still more effectiveness, particularly with a booster. And so you will reduce to some extent your ability to spread and transmit. So that's, you know, we're the frontline people here. I think we should do anything we can, including all our other PPE protection, mask wearing, physical distancing and vaccines, to ensure not just our own protection, but to ensure we're doing our best, all these different levels, to protect the people we're interacting with.
There's a couple of comments come through about myocarditis post-vaccine and whether those people should be being encouraged to have booster doses, which again fits into the which ones would get exemptions depending on. I don't know if Nikki, if you wanted to talk to that. Post-vaccine myocarditis.
Peter, do you want to have a go at mine?
All right, yes, good point. Well, you're on mute.
I can make a comment.
It's words of wisdom.
I was just looking at the Q&A, but yeah, go ahead, Emma. Yeah.
Well, the myocarditis, if they have had that, I mean, it does happen, and so there we have been getting clinical questions that get emailed into us by individuals, but also definitely from general practitioners, public health doctors, asking what is the next best step. And each one is assessed, us and a couple of cardiologists as well. And a decision is then sent back around that. So I don't think it's always going to be a straightforward just to have AstraZeneca. The spike protein question someone had asked about why would AstraZeneca, why not Novavax? I mean, Novavax uses the spike protein also. It presents it in a different way with an adjuvant protein, but they're all using the same antigen part of the virus. But we don't actually know why the myocarditis happens specifically, if it's spike protein related or not. So I think it's very common after with COVID illness too. So yes, we certainly make clinical decisions around people who've had the rare, very unfortunate having myocarditis and what their next best vaccine option might be. And it might be an exemption because actually they could be young and have had 2 doses, and that's more than enough vaccine for them to protect them from this more serious outcomes like hospitalisation.
Okay, thank you. We've got to the question that comes up at every webinar, which is that inadvertent intravenous injection has been shown to be a risk factor for acute myocarditis. I would add in mice, and victims report a metallic taste during vaccination. That's a new one on me. Why are we not aspirating to ensure intramuscular injections achieved?
I think there is one small trial that was done with, I thought they were rats, or were they mice? I'm not sure.
I thought it was mice, but maybe rats.
Where it was injected in large amounts into a large blood vessel. Now, most people on this webinar are frontline healthcare professionals, and you'll all be aware that when you vaccinate into an arm, you might occasionally get a flash of blood from contact with a capillary. That is a completely different situation. And so somebody is translating a clinical study on rodents with what actually is happening in humans. The WHO does not advise aspiration. It can make it more painful, and we're all familiar with the fact that you hardly ever get blood, or if you do, you get a flash of blood. So you're actually talking about very small vessels, capillaries. You are not expecting to inject large doses. So it is not at all comparable with that one study, which is now doing the circuits in social media and getting a lot of noise for it. So I'd reassure all of us that I don't think the WHO is wrong, that we will stick to the World Health Organization advice. Having said that, if somebody personally feels very anxious about that, they're welcome to aspirate. I don't think that's a big concern. What was the second question? A metallic taste?
Yes, I've not come across that, whether that would be an indication that it was getting into the blood vessel. I think that was the implication from the question. I'm not sure.
I think once again, this is a misunderstanding from, utilising some clinical paper, and I've not come across that one themselves. And if somebody wants to follow up with us later, we can go and see if there's any information and any science validity behind that, unless anyone else has got any knowledge of that one. I think once again, these get, they start from a kernel of a single study, and they get completely blown out of proportion, and they make a lot of people very anxious. And once again, the challenge we've got with social media is one small story gets confabulated, and it creates a lot of fear and nervousness. The way we're vaccinating now we've done for many years with confidence. And the other issue to remember about myocarditis and vaccination and aspiration is the incidence of myocarditis is more common in second dose with young men. So apparently, perhaps second dose in young men, the blood are coming into your needles as you inject. So it doesn't make any logical sense either in terms of what we're seeing with myocarditis. So I really think that one is a red herring for most of us.
We're getting a few questions about Novavax. I don't know if anybody wants to just give a brief idea of why people are so keen to see Novavax. And obviously, we're not in a position to give particular guidance on that one as yet, but
So Novavac, I mean, once again, this has got a bit of legs in social media, but look, it is a vaccine that's gone through clinical trials and it looks really good. So it's more the traditional protein vaccine, and it's got an adjuvant with it. So an adjuvant that stimulates your immune system. Most of us know the traditional adjuvants were aluminium. This has got a newer adjuvant in it. So it's clinical trials, it's large randomized controlled trials. It looks effective. It looks like it's going to be a good vaccine. New Zealand has got an advanced purchase order agreement for Novavac, but as yet it's not licensed. Now, the licensure data has been presented to MedSafe, and we're expecting that it's likely, if MedSafe is happy and confident about all the data presented by the company, that we're likely to see approval from MedSafe, potentially even within a few weeks. Now, some of you would have heard that Australia has approved it, and they are expecting to get supplies of Novavac by late February. So all we can say at this point is that I think that it's going through the New Zealand licensure process. It's looking like a good vaccine. I think it may well have a role. We're likely eventually to be in the privileged position of having the choice of vaccine. There's no evidence this vaccine is better than the Pfizer vaccine, so I don't think there's a reason to go with it. There is no evidence at all it is performing better than the current vaccine we've got. The current vaccines we've got, I still believe, are up the best, if not the best, in the world. However, I think we will see Novavac coming into New Zealand, and it may well be available for people who've either had a reaction to a different vaccine or just for personal reasons would like to try a vaccine that is based on a more traditional approach.
I'm conscious of the time. We've filled the time in very quickly, and we've still got a few questions here. I'm just trying to pick the ones that are most common. There's several people asking us to crystal ball look, and what's the future of COVID vaccines? Will they be similar to flu vaccines in the future? I see Peter actually was typing a reply to that one. Do you want to talk to that one, Peter? Because I've had a couple that have been sent in on the same thing as well.
Yes, well, I'm not sure that we obviously don't know for sure, but I think not even Pfizer is keen to see everyone having boosters every 6 months. So I think certainly having it any more than annually, I think would be something that would only be contemplated for the very highest risk group, so poor immune response because of other immune health problems, or perhaps, people over, 75, 80, that kind of thing. the other question, which is going to be coming up, is what about these, tailored vaccines? So an Omicron specific vaccine. And I think, although that's going to be with us soon, I think it's still very early days. I mean, an Omicron specific vaccine will probably be better at protecting you against infection from Omicron, but will it be, better, worse, the same against the next variant, or even against an earlier variant? I think that, as well as, are we going to have fourth doses, fifth doses? I think all these things are things which we don't have to worry ourselves about at the moment, and which are not no-brainers by any means. So I think the thing to focus on for right now is getting those booster numbers in, and particularly, as Nikki was saying, really ensuring that the highest risk people are getting to the front of the queue. That's what we really need to be focusing on.
Thank you. I think we'll just finish off with a couple of questions. I don't know if Nikki, if there's any particular ones that have caught your eye that you want to respond to. If not, I will just pick a couple.
Yeah, I'm having trouble multi-processing.
Yeah, I am too as well. So bear with us, folks. We're trying to do lots of things.
I think the one is people are asking about specific conditions and concerns. Somebody mentioned cardiac arrhythmias, other conditions post-vaccine. Could there be an association with the vaccine? Now, I think what many people are aware of, that the vaccine data, the safety monitoring data, is not just reporting adverse events. We've got really, really big vaccine safety databases now where they're looking at linked data. So like in America and Europe and England, they look at the background rates of conditions like cardiac conditions, arrhythmias, autoimmune conditions, and look at whether there's an increase in these rates in vaccinated populations versus unvaccinated, and in very, very big numbers. You're talking about millions of people. And the other way you can look at safety data is whether there appears to be a cluster of an event soon after you've been given a vaccine. So if you give a vaccine to a lot of the population, you'll have a lot of events happening. Do you see a cluster in a time association after the vaccine? And do you overall see an increase in these incidents after vaccination versus an unvaccinated population? Those are vital pieces of information that we're using to say this vaccine now has got enormous safety data behind it, and we are not seeing increased incidence of autoimmune conditions. We are not seeing increased incidence of neurological important cardiac conditions. Now, there are some potential events that happen straight afterwards. We certainly get reports of people having migraines, their hypertension going up, diabetics maybe, their glycemic control going out of control. They are short-term conditions, and we're definitely hearing reports of stress-related reactions where people are anxious about vaccination. You get, your physiological response can create a whole lot of issues. So events are occurring post-vaccination, and we're very aware of them, and we think them through on a case-by-case basis, but there's a lot of large reassuring data out there with millions and millions of doses now. We've got reassuring safety data with the Pfizer vaccine like I've never seen with other vaccines before.
There's a few questions coming in about early doses for boosters. And obviously, we know the legal stance that we've got is that that vaccinators can give it from 4 months. We don't want them giving it earlier. If they give it earlier, it wouldn't be a prescribed medication as such, because it doesn't fit the legal framework. But there is, Nikki, do you want to talk to any particular issues if it was given a couple of days early?
Oh, look, I think there's two different issues. If it's given an error, we said before that immunologically, you'd rather have a larger gap. If we can at all, we want a longer gap. There might well be cases where we shorten the gap just because we're so concerned about the person's risk of COVID, but it's not an ideal gap. If someone gets it a couple of days earlier accidentally, to be honest, it's neither here nor there. You're talking about the immunological principles of trying to keep a decent gap. So if at all possible, we really would like a long gap to the booster. There may be occasional reasons why somebody might give earlier.
And if people are turning up earlier and you notice that they're earlier, we would prefer that you didn't give the vaccines early. But obviously, if it's going to be really difficult for them to come back and it's only 2 days or something like that, an element of common sense can come into play. But please don't encourage, I think would be, yeah. Okay, and then lastly, is there any benefit to mixed vaccine schedules? Some people are asking now that we've got AstraZeneca and such like out there, should they be thinking of swapping
Mixed schedules do work, and I think there is good evidence now that you could potentially mix and match with schedules. The data to date would suggest still that a Pfizer schedule is looking strong, if not the best, and the Pfizer booster is looking very effective, if not the best. Now, having said that, if there's reasons why you'd benefit from the AstraZeneca or the Novavac potentially when it comes, I think a mixed schedule is looking like it would be effective. Peter, Emma, any other comments? As we run out of time, any other thoughts from any of the questions? We haven't covered them all.
We
I
are
was just
typing
trying
answers.
to quickly whiz through the Q&A, but yeah, I agree, Nikki. I think one of the really great bits of news we've had is that any combination that's been looked at so far of vaccine A and vaccine B all seems to work, you know, very well. So that's been very helpful in terms of people coming from overseas with, you know, virtually any combination of things, and in terms of flexibility in the future. But, you know, I mean, heck, you know, it's only been a year since we had the vaccines, and how much do we know about them already? But there's still going to be more to learn.
I just noticed one question that was sent in that I hadn't responded to, so I'll just do that very quickly before we ask Andrea to finish off with a karakia for us. And that is, can people use the adult vaccine to vaccinate children with? Can we just take 0.1 ml of that vaccine? And it does have the same content, albeit it's got a different buffer, but that's not something that we would recommend, and it's not licensed for its use in that way. The way the Pfizer have created the 10 microgram dose means it's going into a slightly higher volume when you've diluted it correctly, which means it's much easier to get accuracy in dose than trying to mess about with tiny doses of 0.1. So yes, in theory, the contents are the same, but we would recommend that you stick with the preparations for the age ranges they are designed for. Right. We'll leave the webinar running for a little while so people can read some of the Q&As that have just come up. And please don't forget, you can email us directly. We're always available for questions. You don't have to wait for a webinar, Q&A webinar. But if I hand over to Andrea, if you'd like to finish off with our karakia, and I'm still struggling on screen share, so I'll leave you.
Thank you, Jane. Well, first of all, I just want to thank my colleagues for coming along today and giving everybody the opportunity to ask questions. Also, those attendees that have come today, we hope that you've enjoyed today's session, that it's given you confidence to continue your fantastic work out there. And just a reminder that we do have an 0800 line for COVID, as well as your business as usual, your national schedule questions. So please, if you're unsure, please ring us. We're more than happy to take your query, no matter how small or insignificant you might think it is. In actual fact, it's a really good opportunity to talk those through and make sure that at the end of the day, you're confident, you're safe, and what you're doing. And of course, that will then also make your whānau, your patients, confident as well. So everybody, I just want to congratulate you on all your work. And if it's okay, I would just like to finish with a very short karakia. E te atua kia tau tō rangi Māori e, kia runga I ngā iwi o te ao. So thank you, everybody. Have a wonderful evening. And we hope that you've enjoyed today's session. Thank you.
Thank you.
Bye-bye.
Thank you.